Okay, hi everyone. This is live from the first affiliated hospital of Harbin Medical University. And today we are in the Trinity Hospital. So as always, I've introduced my colleagues first. The first operator is Dr. Shi Huaizhang, who's a very experienced doctor treating the carotid and vertebral artery stenosis. And the second operators are Dr. Wang Chunlei and Dr. Li Yuchen. And we have two moderators, and Dr. Wu Pei and me. My name is Li Jianqiang. So first, Dr. Wu will introduce the case.
Hello, everyone. Let me introduce our cases. This is a 60 years old male and have the persistent deafness for 1 month. However, we have treated with the aggressive medical treatment, used aspirin and other drugs. However, he showed no significant improvement in symptoms. He has some risk factors, for example, the type 2 diabetes for 7 years, hypertension for 20 years, and atrial fibrillation for 1 month. And the CT results show he right vertebral artery C4 segment have the stenosis larger than 70%, and the left vertebral artery C4 segment nearly occlusion. Let me show his library data. We can see the glucose is abnormal and his BP is abnormal. Now this is the DSA result. We can see the junction between the basal artery and the right vertebral artery is very stenosis, larger than 70%, just like here. And this is the angiography result. Also, we can see the right vertebral artery is a dominant artery. This is the lateral angiography. We also do the left vertebral artery angiography. We can see it's a dysplasia, and also the C4 segment nearly occlusion. We also do the right intracranial artery and see there's no compensation for the basal artery. And just like the right side, the left side also have no compensation for the basal artery. We do the high resolution MRI. We can see this is there is a plaque at the C4 segment of vertebral artery, and just like the arrow C. And the left side nearly occlusion, like the great arrow C. So we can see the plaque here, and this is the occlusion. This is the left side is occlusion. And this is the CT result, just like the DSA result. The right side is a severe stenosis, and the left side is nearly occlusion. This is the CT result. We also do the MRI and the DWI results show there's no acute ischemia stroke. So today we may use the new instrument, the Fastunnel balloon catheter. It's a very interesting catheter. First, he have a balloon. You can use balloon to pressure the lesion, and also you also can use the balloon catheter to dilate the stent, just like this one. It's a balloon catheter. First, we use the wire across the lesion and use the balloon to press the lesion. And after the lesion, we can use the balloon catheter to dilate a stent. We can reduce the numbers of exchange to reduce the wire puncture risk. Just like the movie, we retreat and delete the stent. Okay. Let me do the survey, okay?
Yeah. So Dr. Shi, I think today we have very good case. It's
Yeah.
different from last case.
Yes.
So 2 weeks ago, we demonstrated the treatments of carotid stenosis and vertebral stenosis.
Yeah.
But today's case is very different. The
Yeah.
stenosis is in the intracranial
Cranial.
part.
Yes.
So what's your strategy for this patient?
Okay. As the professor Wu showed, the patient is both the right and the left vertebrate stenosis. For such case, we should focus on the dominant artery.
Mhm.
In this case, the right one is the dominant artery. So the strategy we should focus on the right one. For the right one, there is a two lesions in the right vertebrae, and the first one is the close to the junction.
Mhm.
It's very severely stenosis, and the second one is it's this one.
Mhm.
Yeah.
So we should put two stand in this patient. For the first lesion, we will use a new instrument, Fastunnel.
Sure.
It's a production of the local Chinese local company.
Mhm.
The balloon caster, we can navigate the stand from the Fastunnel, the
Mhm.
balloon caster. So it's very easy.
Mhm.
And it's a much better than the traditional caster. Yeah.
I say, got it.
Okay.
So I have a question about this case because you just told me the right side is dominant one,
Mhm.
and the left side, the stenosis is very severe, almost totally occluded.
Yes.
But so you are going to leave that because it's caused by dysplasia, or it's because it's not dominant side. That's why we
Yes.
just leave it.
Yes, because it's not dominant. It's maybe it's a dysplasia.
Mhm.
So we don't need to treat it.
Mhm.
And for this case, I think the most important thing is for the first lesion
Mhm.
close to junction,
Mhm.
the lesion, we should know if it's atherosclerosis, stenosis,
Mhm.
or it's hypoplasia.
Mhm.
If it's a hypoplasia,
Mhm.
after we inflated the balloon to treat it,
Mhm.
maybe the result is a disaster. Maybe
Yeah.
it's ruptured.
Uh-huh.
From the DNC, the result we can't tell clearly.
Mhm.
So we
Use
take
high
the
resolution MRI.
HR
Oh,
MRI.
I
Yeah.
see.
From the HR MRI, we
Mm.
can see the blood vessel
Mhm.
blood vessels wall
Mhm.
clearly,
Mhm.
and we can see the plaque here, and we know it's atherosclerosis stenosis, so
Mhm.
we treat it.
Mhm. I
Yes.
see. So the use of high resolution MRI is super
Yeah.
important to
Yes.
can
Very
confirm the
important.
etiology of this stenosis. So
Yes.
right now we are sure because this is caused by atherosclerosis, not dysplasia for
Yes.
the right side.
Yes.
Okay, as you mentioned, you are going to use a very new device. It
Yes.
was
Yeah.
invented by a Chinese company. I think the audience should be very interested in knowing how to use this device. So now you
Okay.
can start your work.
Okay.
Okay.
Yeah.
Oh. So at the first step, I will advance the wire and the microcaster
Mhm.
across the lesion to the base lateral and take a select angle to show the microcaster is in the true lumen of the vertebral of the base lateral.
I see. So because there's two lesions, Dr. Wu,
Yeah, sure.
the distal one is very severe and the proximal is kind of severe, but not that severe.
Yeah,
So
yeah.
our strategy, we will treat the distal, the most severe one first.
Yeah,
And
sure,
then
sure.
the
And then maybe we choose the
I see.
proximal one.
I see.
Yeah, because the stenosis is very severe. So
Mhm.
first we
Mhm.
use the microwire and the
Mhm.
microcatheter
Mhm.
to across the
Mhm.
lesion.
Mhm.
And just like Dr. say, he
Mhm.
need first to do a select angiography
Mhm.
to make sure he's
Mhm.
in the true lumen,
Mhm.
not puncture,
Mhm.
not in some perforator.
Oh, I see.
It's very important. So
Uh-huh.
let me see. We can see we just
Mhm.
across the
I see.
major lesion and
Mhm.
we put the microcatheter and the microwire
Mhm.
to go distal,
Mhm.
distal, and
Mhm.
maybe they can give us enough support,
Mhm.
pulse support.
Yeah, with the use of microcatheter, it's kind of easier to control the guide wire.
Yeah, sure, sure. The microcatheter can help the microwire to go.
Yeah.
Yeah.
So when we deliver the guide wire, we should deliver it as distal as possible, or
Yeah, sure. Because you go distal, you can give me more support.
I see.
Because the microwire, the tip of the microwire, maybe 3 centimeter, is very soft, designed for very soft. So if the microwire is soft, it cannot give us enough support.
1 millimeter junction. It's Andrew.
Yeah. Yes.
We'll do the selective injection,
Yes,
right?
Yeah,
selective
sure.
injection, and to make sure the
It's in the
microcatheter is
true
in the true lumen.
I see.
It's not in the in the. It's
Calling off. We can see he's in the true lumen.
I see.
Okay.
That's very good.
Yeah.
Dr. Wu, it's kind of controversial, whether or not to treat intracranial vessel or intracranial stenosis with the interventional approach. It's kind of controversial. So far, there's no studies confirming the efficacy of this interventional management. So what's your thought on this? At least what's the indication for this patient?
Actually, there's just like you see, there's some controversy. The most famous trial is the Sunrise trial. He do a compare because the Stent and the traditional medical treatment. The result is not good for Stent, but the trial have a lot of problem. For example, his patient selection and the operator do not have enough cases.
I
Okay,
see.
so in the real world, American also do two trail, the Wave trail and the Wound trail, just published maybe 3 or 2 years ago. He see for if you select the patient carefully, he have more good result. So in American, as I know, for example, one patient have a mini stroke due to the lesion. He just use the medical treatment, but he will have a stroke again. So let me choose the Stent, just like us. For this patient, we know he have two vertebral artery. One is dominant, another is nearly occlusion and the depth spacing. But the dominant is the Stent severe. Once the dominant occlusion, the patient maybe have severe mobility or motility. So for this patient, we advise use the Stent.
I see. Got it. So right now, Dr. Shi is exchanging the wire.
Sure. We choose 30 centimeter wire to exchange the micro wire. Then we use the Fastunnel, just like Dr. say, the new device.
Yes, we changed along 300 millimeters the wire, and from this wire we will advance the Fastunnel, the balloon caster. Yeah. Yeah, for the intracranial stenosis, the standing, the operation, the most dangerous, the complication is the blood rupture. It's bleeding. We are very concerned about this complication. So we should use the very soft wire at first, and with the microcatheter, and after the wire's assistant, we navigate the microcatheter to the very far. And after that, we make sure take a selective with the angel, make sure the microcatheter is in the true lumen, and after that we navigate 300 millimeters along the wire, and after that we pull back the microcatheter, and from the long wire we navigate the balloon.
Okay, I see.
And the question you asked why we treated the intracranial stenosis because there's no clear evidence the clinical trial because the intracranial stenosis is the main cause of the stroke in Asia, especially in East Asia. It's very different situation
From
compare with
North America or European.
compare with the white people. You know, so it's about half, 50%. 50% stroke in China is because of the intracranial stenosis. So even the result of the SUNPRESS trial is
negative.
Is negative, but we found a lot of the patient of the intracranial stenosis patient we treated, and the patient get benefit from the operation. So we also treated this patient. And from the cases trial, because the trials, the result is published on the JAMA and last year. It's a Chinese
multi
trial, RCT trial, and our center is the one
also join
participate in this study.
And the results showed there's no benefit from the standing, but the dangers, the complication rate is the same compared with the medicine group. So maybe we should do a more clinical trial, maybe a long-term follow-up will show the good results. Fastunnel.
Fastunnel.
Yes.
I don't know if the camera can give us a close shot to let us to have a better look at this new device. I'm not sure.
Yes. Before this device, we use the wingspan stand and gateway balloon. The system is Strike company's production. But I think it's much easier than the gateway and wingspan system. Yes.
So as Dr. Shi mentioned, the result is kind of negative. Maybe it has something to do with the experience of the doctors. The doctor is very experienced and the complication rate should be low. So patients may get benefit from this interventional procedure. And I think, because of the numbers of device exchanges, if it's too much, that may increase the risk of complications. So right now we have a new device, we can decrease the number of device exchanges. I think this will definitely decrease the risk of complications. And again, patients get benefits from this new device.
It's 100. It's what's the is Emoy? Hester is guiding. The guiding is
because
it's 100
for this
90?
100.
Why?
Because for this Fastunnel cannot across the 19 gather.
Oh. In this step, we should focus on the tip of the wire. We should remain is very, very stable because we are very, very worried about it can rupture the it's through the branch and make the blood rupture. So stable is a good.
Once the wire is engaged, so any movement should be careful, right?
Sure. For the operator, he need to focus on the tip of the micro wire. If the micro wire across or go, maybe puncture the perforator or puncture the vessel. So we can see the marker of the Fastunnel here. Let's see.
There are 3 markers, right?
The first one may be the catheter tip, and the second one and the third one may be the balloon.
The balloon size.
The second and the third one between is the balloon.
I see. No, it's engaged already.
So no, sir. Maybe we need to angiography to make sure the lesion.
Yes.
Okay.
Let me pull back a little.
Okay. Be carefully, because sometimes angiography the pressure is very, very high. Maybe focus all the system go go ahead,
Uh-huh.
so may puncture the vessels.
I see.
We put the balloon as a lesion. We need to make an angiography
Mm-hmm.
and maybe withdraw.
Okay, okay, okay. Okay.
Okay, go now angiography.
Angiography. Okay.
Spasm. Yeah. Okay.
Vasospasm.
Yeah.
Vasospasm.
Okay.
Mm-hmm.
Yeah.
Okay.
So are we going to give some medicine to
Because-
treat this spasm?
Yeah. Because the Fastunnel is stiff, very stiff.
Mhm.
After that, sometimes it's spasm.
So we just dilation directly.
Mm-hmm.
Okay. One,
The normal pressure is 6. Is 6.
Mm-hmm.
2, three.
So when we use
Three.
this Fastunnel device, this spasm happens very often, or sometimes it doesn't happen very often. Just sometimes.
4.
Actually, we only use a few
I
Fastunnel,
see.
so we don't have a large result.
Uh-huh.
But for stenosis here, the
Mhm.
vasospasm is very common. It's very
Ah.
common.
I see.
Use other device also has this problem.
Mm-hmm.
6.
And sometimes the vasospasm is a problem. Another problem may be the stenosis with sphere. So when the balloon
7.
local in the lesion and the vessel may be occlusion. So
Mhm.
undergo so just like a vasospasm.
Mm-hmm.
8.
And the patient may have some symptoms, I think.
Yeah. We so we do not operate a very long time.
Mm-hmm.
7.
And before operator, the patient also needed
6.
to take
5.
antipletic drugs.
Mm-hmm.
3, 2, 1.
So
For the intracranial standing, we should, when we inflate the balloon, we should very slowly and
Angiography.
slowly,
Mhm.
because it can decrease the because it can decrease the dissection rate. Yeah. Okay.
Mhm.
So
What
maybe
do you think?
angiography again, sir.
No. I think it's good.
Okay.
Very good. Yes.
So, Dr. Wu, I think it's much safer to do the interventional treatments for the vertebral artery than the carotid artery, right?
Sure.
So, because last time, when we inflate the balloon, the patient's BP was dropped and heart rate was also decreased. But this time, it's a kind of okay, right?
For vertebral artery, the heart rate cannot change because it's the lesion is intracranial.
E2
Just
stent.
for the carotid artery.
What the length?
Yeah.
What the length is good?
Maybe 23, sir.
The length? I will measure it.
Okay.
Okay.
Doctor will to choose
From
stand,
here?
choose a stand.
Mm-hmm.
The length.
Maybe 16 or 23 because he has the two tab. You know,
23.
sir?
23.
Okay.
3.
23. Okay.
Yeah.
Open.
23. Yeah.
If it's a coronary intervention, we may use some imaging devices to measure like the diameter of the stenosis and
Give me the
movement
roadmap.
area. But in
Roadmap.
this kind of treatments, you always use DSA
Yeah,
to
sure.
do this kind of measurements, right?
Sure.
Yeah.
So now we use the self-expanded stand called Enterprise 2. Enterprise 2. The Enterprise 1 is made in Cordis company. The first one, the Enterprise 1 is used for the assisted coil aneurysm. But because it's easy to delete, and now the E2 has been used for treatment the stenosis in European. He has some clinical trial. Now it's beginning. Also China, we also do the trial for the E2 stand for the stenosis.
Yeah.
Now we can see this is the stand.
From here to here.
Yeah.
Okay.
This is no tape one?
Not tip, not tip.
Yeah.
Yeah. Not tip is more safer, I think.
Yeah. The E2 stand have two tabs. First one have the tab, have the tape. It can make the stand very when delivered, it's very stability. Another one is no tape. Because if this one have some tape, maybe puncture the basal artery.
I see.
So for this one, doctor choose the no tape one. Yeah. It's open, sir.
Yes, I know.
We do angiography
Yes.
first to see whether there's some spasm.
So before the release of the stents,
Yes.
I think it's good. It's good.
It's good.
Okay, give me.
So single and microwire.
Yes. Yeah. Single and.
Maybe, sir, you can use transcend like this one as a microwire, or you treat all the system.
We treat all the system and we change.
Okay. Single.
And plus
single.
the plus caster and the single. And plus caster.
Plus. Okay.
So the first layer we finished, and the result showed it's good. Yeah. And after that we will treat the second layer.
That is why you want to change the whole system.
Now use first.
What's the reason behind this?
Because it's too stiff, I think. Yeah. So if the Fastunnel system is still in the vertebral artery, and we take the angio, we show the spasm. The spasm, and we can't tell if the lesion is good. So I put back, retrieve all the system and take angio and show we can see clearly the whole lesion.
So, sir, this is a microwire. Maybe I would advise. Oh, sir, here. Maybe I would advise you use the actual 10 first because of the micro catheter maybe easy across the stand. Okay. Actual 10. Okay. This one. Okay.
And for you can see for the intracranial lesions, we do the operation. We should maintain all the table clearly, no blood.
Yeah, very clean. Yeah. I like this. It's not like the coronary interventions. There's a lot of blood on the table.
You don't need it.
We don't care about
that.
Yeah,
because we are very concerned about the thrombosis in the cranial. Yeah. More. Okay. Go back.
So Dr. Wu, for the first stent, we chose the self-expandable stents. So if it's intracranial stenosis, we always use self-expandable stents, right?
Sure. Most time for the intracranial stenosis, we use the self-stand. For example, the MC and the artery and the basal artery, because in this station we have a lot of perforator artery. If we use the balloon mounting stand, we delete it. Maybe we lead to the perforator occlusion. It's very common. So for most time we use the self-expand stand here.
I see.
Yeah.
Just in case the occlusion of the perforation branches.
Another reason is because the balloon mountain stand is very hard, it's very stiff. It cannot easy to
deliver.
Yeah.
I see.
And the third reason, is in some cases the distal and the proximal of the lesion, the size is
diameter. It's
so
different.
For this case, if we choose the balloon expanding stand, it's very hard to choose the size of the stand.
I see.
So if we use the self-expanding stand, the balloon we should a small one, just as the distal size, distal part segment size, and the stand we shoot a larger one. It's as the proximal segment size.
Yeah, because the size, the diameter is different. If we choose a large one, maybe distal maybe rupture.
If it's small one, we cannot like
Yeah.
do the post dilatation.
Sure.
Yeah.
So we most times we choose self-extend stent. It's more safe. So, sir, maybe you want to try exercise, microwire.
Let me try.
Single is it's not very easy, I think.
Dr. Wu, do you think right now it's kind of harder to maneuver the wear because there's a stent implanted already?
Sure. Just I
Traces.
talked with the Dr. Shi. This wear is the single wear.
Mhm.
It's
More stiff.
more
Which
stiff and
is
but it's
soft.
easy to control.
Mhm.
But the tip is not soft enough.
Mhm.
Now we change another
Soft
soft
one.
one. The track size software is
Mhm.
made in migration company, I think.
Mhm.
Migration, yeah.
Mhm.
The tip is more soft, easy
Mhm.
to across
Mhm.
the legend.
Mhm. So before the use of wear, we also have to shape the tip.
Yeah,
of the
maybe
wear.
the G shape.
G shape.
Yeah.
Uh-huh.
Now we see
Oh, we
it's
got
very
it. Yeah.
easy.
Yeah, it's very easy.
Yeah. I think maybe the macro go across the cell of the stand, so we across it again to make sure the true lumen.
So how can we make sure, if the wear goes through the cell, it goes just through the true lumen?
Sometimes we can see the macro Kaiser because we know across we to push the macro Kaiser, we can see the cell maybe not stability.
Uh-huh.
So sometimes maybe from the cell of the stand, maybe because it's influence the stand. We need to retrieve the tip of reshape the tip of the macro wire.
Yeah.
I guess why the wear may go into this because it's a self-expandable stance. It cannot be opposed to the vessel very, very good.
Sure.
Right?
Because it's
Yeah.
a closed cell stand. Sometimes he not you see, yeah.
So if we cannot get the wear through the true lumen, except to reshape the tip of the wear, any other methods we could use to solve this problem?
Sometimes maybe use another microwire. Just put a microwire tip here. Use a more strong wire, just like here, and we put the balloon to the lesion. But I think it's very difficult. So maybe you can use the gateway. Just put the tip. Oh, okay, across. But the we can see the micro catheter across is difficultly, I think.
Mhm.
Okay, okay, we'll cross. We can see the tip of the microcare here. Okay. Select angiography. Okay. Okay.
Yes. 300.
Transient. Prepare. Okay.
Uh, gateway.
Angiography maybe.
I
First
will try to plus the caster. Yeah, try to plus caster. If it's easy to cross the stand, it's demonstrate. It can make sure it's in the true lumen. If it's very hard, very difficult to cross this part, maybe it's from the cell. So I will.
So maybe just dilation. Okay.
Yes. Yes.
Will not do the stand.
Yes. Yes.
Because we will not make sure whether the catheter across the closed cell. So
300.
just
Balloon dilatation.
balloon dilation first is safe, I think.
Yeah. So what's the size of the balloon?
The first balloon is 2 by 15. The second one we will choose the 3 by 20 or 3 by.
We'll
Yes.
start from the small one.
Yeah.
It means the distal stenosis, we choose the 2 by 15. Now this lesion, we just use the 3 by 20 directly. Okay.
But you know, there's a problem with the balloon dilatation only. You know, after the balloon dilatation, you know, over a long term, the vessel may recoil.
Yeah,
after
sure,
a while,
sure,
right?
sure,
that,
sure.
that should be a problem.
Yeah, but I think some, the drug mountain blue maybe used maybe
It's better.
Yeah, maybe better.
But do we have that available in this
No,
catalog?
no.
Okay.
Sure.
Oh.
Okay. So make sure prepare the balloon. Okay. 3 by 20.
3 by 20.
3 by 20.
It's gateway or gateway?
No,
or
not gateway.
Oh.
Exchange, rapid exchange.
What's the name?
Let me see. What's the name of the balloon?
You're right, Dr. Shi. I think last time you told me, you know, when you do this kind of procedure, the cooperation between you and your second arbitrator is super important.
Yes.
When you put back the microcatheter and the other after has
need
to.
a group,
I think
a team.
this balloon maybe some hot. Bart.
It's soft one.
Maybe it's a little hard, but we only do have this one.
Oh.
Okay.
I will try. I will try. Okay. It's for the.
Yeah, for
intracranial. Carotid or for the intracranial?
For intracranial.
Okay.
Maybe a little hard.
3 by 20.
Yes. 3 by 20. So, boss, maybe you do angiography first?
Yes.
Because vasospasm,
Yes. Wait a moment. Take angio. Take angio.
Angiography. Okay.
Give me the roadmap.
Now we do angiography first because we worry about if the balloon to reach the lesion, maybe vasospasm again.
I see. Okay, what's the question? Uh-huh. Professor Shi, did
Yeah.
you get the question? What's the criteria for the use of Fastunnel
Yes.
device?
What?
The criteria, the patient selection for this new device.
Yes. 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 Because the fastener is more stiff than the wingspan and then the gateway,
Mm-hmm.
so we only use for the stretch vessel,
Mm-hmm.
and the distal part is very clearly and very straight,
Mm-hmm.
just
Oh,
for such case.
I see. If the vessel is kind of tortuous, maybe
Yes.
Yeah, we can
Fastunnel
use
is
this
not a
one.
good
It's
choice.
not a good
Yeah.
choice. Yeah.
I see. Anything else?
Another question?
Oh, no, no, no. I mean, for the
Oh,
use of this new device, anything else we should be aware of?
for this case, because
Uh-huh.
it's free.
Okay.
So very hard, I think. Very tough.
Small. Social. Small.
We need to see the hazard.
Okay.
So because the balloon is very hard,
Mhm.
so now you can see the castle have been pushed down.
Mm-hmm.
So now when the operator feel, oh, we cannot see the tip of the cathode,
Mm-hmm.
we need to make sure where the cathode.
Mm-hmm.
Oh, sir, you need to focus on the tip of the
Yes.
wire, okay? Oh, okay. Good. Just here is okay. So now pressure is also 6, sir. Okay.
Okay.
Now we can inflate the balloon.
One.
Sure.
1,
Slowly by slowly.
2, 3, 4, 5,
So we'll give the pressure to 6 atm
Wow.
gradually.
Yeah.
6. Okay.
Okay.
5, 4, 3, 2, 1. Okay, take Andrew. Plus. No.
What do you think of the results?
It's
I
good.
think it's good.
Mhm.
The stenosis display, and we think we can try to delete the stand.
Mm-hmm.
Plus.
Yeah, it has been prepared. So maybe we'll need another E2. Longer than 23. No, it's not long enough. 30, okay? 30 or 37.
So we decided to stand here.
Yeah,
Okay.
sure.
More water.
So because we can see there's some white in the lesion,
Mhm.
so we be concerned whether this is decision, decision. So maybe stent is more safe.
Mm-hmm. Dr. Shi, because
Yes.
right now we are kind of worried. Maybe there's
No tape,
dissection.
okay?
That's why we decided to stand here.
Yes.
But
Okay,
if
okay,
there's
okay.
no,
Perfect.
no possible of dissection, we just leave it, right? Only balloon dilatation.
If this the lesion is very short,
Mhm.
it's very short. If after the balloon inflating, there is no dissection
Mhm.
and stenosis is not very high.
Mhm.
I think I will leave it alone. I will leave
Okay.
it alone.
Uh-huh.
Yeah, but if the dissection or
Mhm.
like this case,
Mhm.
the lesion is very,
Very
long,
long.
Oh, I
very
see.
long.
Yeah.
I'm worried about the long-term result is
Mhm.
not good.
Mhm.
Just if just the balloon. Yeah.
I see. It's better to put it stand here.
Yes.
Yeah.
Oh.
Oh, no. So,
think
sir,
it-
maybe
I think
here,
it's
and we
okay.
choose a no tape one, okay?
Yes.
The two stand not cover,
Yes. Okay.
just here, okay?
Okay. Okay. No tip.
No tape, okay. How long? Maybe 30? I think 23 is not enough.
37.
37.
39. 39. Long one. Long one.
30 is enough, I think.
No,
From here to
maybe
here,
from
30.
here
Oh,
to
okay, okay,
here,
37.
yeah.
39, no tape.
Because I'm worried about the dissection.
Yeah,
The
sure.
long one should
Because
more
maybe
safe.
here it's a dissection,
Yeah,
so
more
we
long.
need to cover it.
Mhm.
Yeah, more
Yeah.
long, more
Maybe
safe.
dissection from
Yeah.
here. Maybe.
Yeah, we have to make sure all the dissection are
Yes.
covered.
No
in the
tape,
stance.
no
the
tape.
part, all the lesions
Okay.
should be covered by the stand.
Yeah.
So I prefer a long stand, self-suspending stand. As
Yeah, right. I think. So because of the previous stance, we cannot put this stand with the tape, right? We
Yeah,
have to put this stand
yeah.
with no tape.
Not tape.
Yeah, because the microcatheter
Mhm.
cannot go very distal.
Oh, I see.
So
Got it.
to make sure no tape is more safe, because
Mhm.
tape may puncture the vessel.
Yeah, right.
And we think the stand, two stand not cover, sir, okay?
Let me
Because
try.
you now make sure,
Yes,
whether
I
it's in
know,
the closed cell.
I
You
know
know
what
what
you
I
mean.
mean? Yeah.
I know what you mean.
Yeah.
Yes. Let me try.
Because we're not sure whether the microcatheter is go inside the closed cell, Dr.
Mhm.
So
Mhm.
we to put another stent, not cover another stent, because maybe if it's in the cell, the distal stent cannot open.
Oh, I see.
Yeah, so. Oh, okay, it's a delayed. Angiography.
Andrew. Oh, a dissection
Yeah,
here.
we can see
Yeah.
the section here.
Yeah. So if we just leave it alone and
Mhm.
not put the stand here,
That may cause some
maybe the
problem in the
result is
future.
not good.
Yeah.
And what's the vessel you mentioned before the operation?
It's still here.
Here?
Okay, I see.
Here. Okay.
I see.
Because there are some important
We can see the perforator here.
Here.
We worry about if the perforator occlusion,
uh-huh.
maybe the
Maybe,
patient have some symptoms.
Spinal cord.
So for the distal lesion, we choose a small one,
I
only
see.
2 millimeter
Okay.
balloon. Okay.
But we didn't lose the perforation branch.
Yeah.
That's very good.
Yeah, we should also focus on the perforator after the operation. If they're still in it. Yeah, if there's no perforator,
So, sir, this
especially for the important perforator, we should take some medicine in the arterial tirofiban, and make the perforator so
some injection anti.
Okay, take Andrew.
Angiography again.
Okay.
So, sir, here, do you want to deletion again, or just leave it like this?
I think I leave it.
Okay.
Yeah, leave it alone. Yeah. Oh, it's okay. The APVO and the lateral.
Yeah. Okay.
Okay, we finished it, and we will give some tear feedback.
Yeah. Some. So now we want to inject some antiplatelet drugs
Mhm.
to protect or protect the perforator. They just inject from the catheter. Okay.
I see.
So, sir, do you want to do a CT scan first to make sure whether there's some hemorrhage? Okay.
Yeah.
And then we just give the give the drug.
Okay.
Do CT scan first. CT scan first.
Yes. Before we, because we
Before
are
we
very
inject,
worried about
first.
the
Dissection.
not dissection, but rupture,
rupture.
bleeding. So before we inject the terifibin, and we should take a CT view, CT scan, make sure there's no bleeding, no bleeding.
I see.
Yeah, maybe more safe, sir.
Yeah,
Because
right.
when the blood dilation, maybe some perforator maybe rupture.
Yeah,
Yes.
you're right.
Yeah.
If there's bleeding, we still give the
Yes.
antiplatelet
It's
therapy.
devastating.
Yeah, it could be disaster.
During the
Yeah,
operation,
that's
intracranial stenting operation, we should tell us the bleeding.
Yeah.
Not bleeding. Yeah.
We have to always remind us.
Yes,
yeah.
remind
Several
us,
hemorrhage.
yeah. Okay, well, we can.
Okay, I think time is enough. Just
So,
do CT scan. Okay.
it's not an easy case, I think,
Yeah,
because
sure.
two stent and two lesion in the one arterioles. And
Yeah, right. This is a
Yes.
very complex case.
yes,
Yeah.
yes,
But I think with the new device, we
Yes.
decrease the number of exchanges.
yes,
So
yes.
that should decrease the complication
Patient,
rate. Yeah.
I think, yeah.
Check it. Okay. Check it. So I think it's good, sir. No hemorrhage. Okay.
Okay.
That's good.
No
So
bleeding.
injection.
Okay. So I think the result is very good. So,
Yes.
Dr. Shi, before we finish this procedure, any final words for this case?
Yes.
Yeah.
For the intracranial stenosis, even there's no clinical trial to prove that to have the evidence to prove that it's efficient. But in China, lot of the centers we do, including my centers, we do a lot of such cases, and the result I think is good. But I think we need more clinical trial to prove the intracranial standing is infectious. Yeah. So in this case, we know from the it's not easy. It's easy case. It's complex case. I think. But there's a lot of new instrument and it's a lot of new technique, and it's help us to make the operation more safer. So I think in the future, the intracranial stenosis, the standing, maybe have a good future. Yeah.
So Dr. Shi, do you have the confidence, because this new device, the Fastunnel, will be widely used?
I don't think so. Actually,
you
yeah.
don't think so?
Yeah. Because it's more stiff. It's more stiff, and I think for such case it's very straight. The vessel straight, especially the distal part is very long and very straight. So in that case, it's okay. But it's very tutors, and the distal part is very small and very tutors. I think it's very dangerous.
Yes.
So, yeah.
It depends on the lesion characteristics.
Yes.
Some patients, maybe this is good choice.
Yes.
For some other lesions, it's not good choice.
Yes.
Yeah. All right, audience, I think today we have shown a very complex case, also very interesting. We choose a very new device. So as you can see, we did decrease the number of device exchanges. So I think these patients may benefit more from this new device and also this procedure. I think Dr. Shi Huaizhang, Dr. Wu Pei, and also other doctors, nurses, technicians, they have sacrificed a lot for the success treatments of these patients. And thank you so much for watching. Hope to see you again next time.
Thank you.
Bye-bye.
See you.
Bye-bye.
Okay.